everyone. Thanks, Barbara. Just like Dr. Garcia was saying, my name is Alex Auslander, and I'm one of the faculty here in the public health program. And I'm going to focus on talk about my research today, more specifically the ACEs Aware practice grant that myself and more a larger group won this past couple of years. And the practice grant is preventing and responding to adverse childhood experiences, ACEs, associated health conditions, and toxic stress in clinics through community engagement. Yeah, that's a mouthful. And so that I'm going to talk about that in just a few moments. I want to talk about a little bit what ACEs are, and kind of where they stem from first. So the original ACEs study was in the late 1990s, 1900s, 1998, and it happened in San Diego. I know, it sounds crazy. It happened in San Diego County through Kaiser Permanente. And what they looked at was things like household dysfunction, abuse, and neglect. And they identified 10 factors that had an impact on neurodevelopment in children, young children, ages 0 to 5. And then how that eventually impacted things like disease, disability, social problems, and eventually early death. And what they found was this dose response. Oh, can you go back? They found that this dose response. Basically, the more ACEs you had, the more likely you were to succumb to these conditions, right? More likely to use do risky behaviors like intravenous drug use, teen sex, things like that, and eventually mortality, right? They found that if you had 6 or more ACEs, you actually were potentially at risk for dying up to 20 years earlier. So all of this was a huge landmark study. But the problem was this study focused on residents in San Diego County, which were middle to upper middle class white community or population. And in 2012 and 2013, there was another study done called the Philadelphia study. And this looked at more of an urban context. And what they found was remarkable. They found that, yes, ACEs have this impact, but ACEs is not the bottom of the pyramid. What the bottom of the pyramid is this historical trauma and this generational embodiment that's been happening for decades. And this historical trauma causes something called an epigenetic effect. So historical trauma that happened to parents, grandparents, great-grandparents is passed down to further generations. And what they also found as this impact, the impact is this lack of ability to handle stressful situations. Right. On top of that, so then there was this historical trauma at the bottom. There was also these things called adverse community environment, social contexts, things like increased violence, things like bullying, food deserts, food swamps. All of these also had this impact on how not only the rate of ACEs, but on the disrupted neurodevelopment that eventually leads to this disease, disability, social problems, and then early death. And then there's been this consensus that this high accumulation of all this adversity that's been happening, and which is the key part is here, that there's not a stable environment, a nurturing environment, can lead to this long-term disruption in brain development and immune, hormonal, and metabolic systems, and this through this genetic, like I mentioned, this epigenetic aspect of it, regulatory mechanisms. And this collectively is known as that toxic stress response. So in this grant that we've been working on, we're looking at toxic stress and how to create resilience to this toxic stress that is caused from things like historical trauma, social conditions, and then, of course, ACEs. What's this? Oh, and then we also are looking at this mostly in these periods of times of transition. So there's 3 periods that we focused on. One is going from high school to college. The next is going from parenthood. So not quite middle life, but parenthood. And then also for the elderly community. All right. So these are the kind of the transitional periods. Move next, Barbara. Thank you. Some of the goals of the practice initiative, you're welcome to scan the QR code to give you much more information on the grant itself and the community partners. But there were 3 main initiatives to this practice grant: strengthen partnerships, develop sustainable new evidence-based services, and expand the workforce. And all of these to fill these gaps in services to effectively respond to fill these gaps in ACEs and toxic stress in these communities. And especially specifically in communities where there were high quantities or prevalence of Medi-Cal beneficiaries. And if you're not in California, Medi-Cal is the same as Medicaid beneficiaries. So these federally funded healthcare or federally assisted healthcare. So kind of talk about the three different, this is kind of more the systems approach, systems thinking approach. The three different areas were workforce development, right? We talked about that. Services, which is going to be your health and wellness services, and then community partners. All right, so there were some major community partners. All of these partners served these populations for Medi-Cal. Tri-City Mental Health, East Valley Community Health Center, CITRI, which is the Community Translational Research Institute. And then one of the, there's two major academic institutions. One was Cal Poly Pomona, and the other was Claremont Graduate University. I used to work at Cal Poly, and I went to school at Claremont Graduate University, so I had a connection through there from the past. And for the services, there were things like physical activity programming, nutrition programming, and psychosocial programming. And I'll talk about that in just a second. But this idea is that we went into the community and we also went to the different schools and we would screen for high levels of ACEs. And there was a questionnaire that went out and they screened, and there was also biomarkers done, and other type of biological tests done, like high blood pressure, hemoglobin A1C, things like that. And these people that had tested high for ACEs will get put into these different programs, right? We get offered programs like physical activity, nutrition, and psychosocial education, which have all been shown to create resilience to ACEs. Those who tested high for things like diabetes, which is also, there's a lot of correlation between the two, will get enrolled in programs like diabetes prevention programs, diabetes management services, and then other health and wellness coaching. There was a workforce that was also developed, and you can see I circled it, it got cut off, but West Coast University was the BSN students did a lot of the different screeners, and they worked in a lot of the different trainings and service delivery. And then also we had community health workers. And so some of our faculty, faculty, but I meant some of our students actually went through the training and would help doing these services in the community. So they were on both sides. And these services, actually you can go to the next one, Barbara, please. There were three major programs. There was a nutrition program, social wellbeing program, and then the physical activity program. And all of the community members and students who screened high for ACEs were automatically enrolled in these programs. And they were all virtual programs. I'm going to focus a little bit on the physical activity. I'll just give you a snippet of what it was since I developed it. Basically, it was an online asynchronous module to breaking barriers to physical activity. So answer questions about why are you not physically active? And then they would answer that, and then they would kind of go through this full asynchronous recording about how to break these barriers. And at the end, they could opt in for personalized one-on-one counseling to help break these barriers completely, hopefully. All right. So we just finished, the grant just finished up, and actually the final report's due on Monday. So a couple of things, the preliminary results, a large finding in community members and students had at least one ACE, and more specifically, a lot of mental health conditions, anxiety, depression, suicidal ideations, a lot more on that end of the screener. But we also found, and in the next slide, I'm going to talk about it a little bit more, that there was a lot of potential limitations to the study. So just kind of in the theme of APHA, next slide real quick. And the theme, I'm not going to read this whole thing, don't worry. But in the theme of the APHA, we submitted, but took the lead on it, abstract that looked at more specifically the caucus for the academic linkages and partnerships for the communities. And we wanted to talk about what were our struggles, because that was kind of the main issue. We had all of these services in place. We had all of this grant funding in place, but we didn't have a strong outpouring of people wanting services. And so what were some of the reasons behind not wanting all these services? Because we had a lot of people do the screeners and they tested high for ACEs and high for other toxic stress issues, but they didn't want to do the services. So what were these issues? Well, they included issues with academic institution linkages, trust in public health services, and then again, this collaboration between academic and community partners is a problem. In academia, there is a lot different types of red tape to walk through than you would in a community environment. One of the main things are FERPA regulations and what to do if somebody says they have suicidal ideations, right? We have to be able to provide services for people that are having these thoughts. And so it was mandated reporting. And so that was a lot of jumps to go through there. And again, with this Title IX and counseling services, there was a lot of hoops to jump through with that. In addition, this mandatory reporting, maybe students didn't want people to know that they had suicidal ideations. Maybe they didn't want to know that they grew up in abusive homes, right? Because if they did say that, I was automatically flagged and it was reported. So there was all of these jumps or hoops to jump through in academia. Now on the community side, there was a lack of mistrust because there was this time lag between community screenings and introducing programming. So at times it'd be 2 months between when they were screening the community and we got referrals, right? That time lag hindered this ability for people's actually interest and comfort with working with these providers, right? Another thing is there was Google surveys that were sent out, which is a little bit, not really sure about that. The trust has dropped completely, or not completely, but dramatically. And then also these ideas of face-to-face virtual meetings heightens apprehension, especially if you're not used to that provider. So there was a lot of issues working with community members and academia and these programmings. There was just this major time lag. In addition, after COVID, there's been a lot of lack of trust in public health and public health services to community members. And so there was that issue as well. Basically found, okay, what do we want to do next steps? Because this practice grant was to get infrastructure in, not necessarily to gather data. What can we do next? We need additional budgeting for screenings. We need to develop these relationships with Title IX coordinators and counselors on campuses, and then improve these virtual interactions to hopefully overcome these challenges. And that's kind of the goal. And that's what we're going to write up in a report. And so hopefully this practice grant can move from an infrastructure grant into a grant of actually disseminating more of these services and collecting data to see what actually happens, and hopefully we can create resilience in these communities that are high levels of ACEs. So if you are interested in this information or in this kind of research, please don't hesitate to reach out to me. I also do some research in epigenetics as well. So if that part is interesting to you, please let me know. And yeah, it's been a pleasure.
Thank you so much. That was fabulous. We will field any quick questions that we have. Anybody? All right, you can always put them in the chat and we can go ahead and read them there. Thank you so much, Dr. Auslander, and Dr. Gagandeep, you're up.
All right. Well, thank you, Dr. Auslander and team here. So today I kind of want to speak about what I've been up to. So I work as a consultant for NEHA, which is the National Health Association, and part of a grant right now. It just actually also ended as well as just ending